Good evening, everybody. On behalf of IAGES, I'm very pleased to welcome all of you for this second IAGES International webinar. We are very fortunate to have so many international faculties and also President of IAGES, Dr. Raman Goel, is here. So I will request first Dr. Raman Goel to welcome all the faculties on behalf of IAGES before we start the webinar.
Good evening, good morning, friends. Are you able to see my screen?
Yeah.
Yes, we are.
Okay. So it's a great opportunity to meet senior people like Professor Salki, Eduardo, President of ELSA, Sutep, Ahmed Nissen from our backyard, our friend, and Dr. Roy Pachankar, who is a senior surgeon from Mumbai, joining us, and our moderators, Dr. Sunil Popat, who is going to be the president of IAGES next year, and Dr. Randeep Padhavan from Delhi. So friends, as is customary for these international webinars, I am required to give a brief introduction about the IAGES. As most of you know, this association was started by visionary Professor Chantan Odwadia, who was also awarded one of the that's Padam Bhushan by Government of India. IAGES was established in 1993, which is makes it almost 27-year-old organization with 8,000 plus members. These are mostly laparoscopic surgeons, and IAGES is a member of IFSIS and ELSA at international level. IAGES also is a collaborating association for from Bangladesh and Maldives. That means we have continued academic activities with them, and they are also co-organizers for our international events. IAGES has a journal, a peer-reviewed journal, which is published every 3 months for last 16 years by Walter Kluwer, and has been a major academic exercise done by IAGES, started again by Professor Odwadia, who was the chief editor, and at the moment, Dr. Pradeep Chaube from Delhi is the chief editor of this journal. IAGES had been, as I said, is an academic organization, had been actively publishing textbooks on laparoscopic surgery, which is provided to all of our members on regular basis. This is the 4th edition of which I had the pleasure to be a co-editor, and also has recent advances in minimal access surgeries on a regular basis, published by Dr. Subhash Khanna. IAGES also has recertification programs, which is in essential laparoscopic surgery, what we call as fellowship of IAGES, and then an advanced minimal access surgery, which are in 7 subjects, 7 specific subjects, like hernia, bariatric, upper GI, colorectal, oncology, robotic. We also have a very strong presence in GI endoscopy. So IAGES trains surgeons to do the flexible endoscopies, GI endoscopies themselves. So we have an endoscopic fellowship program of IAGES on essential endoscopic program. And we also do advanced endoscopy training program, which is called FAGI. And all of them have been converted online once the COVID has started. So from 15th of July, we are expecting all these programs, the lectures are being recorded and the modules have been prepared, because we don't see COVID going away. And during our national conference, we have a large convocation ceremony where all these people who have been recertified or who have gained fellowships, they come together. Almost 1,000 or 1,200 surgeons come for this convocation ceremony, which is done on the last day of our annual conference. IAGES also organizes collaborative conferences, mostly overseas as a midterm meeting. So 2017, we were in Sri Lanka. 2018, we were with Dr. Ahmed Nissen, who was part of the panel today, in Maldives. And 2020, July, we are supposed to be in Edinburgh, which was in collaboration with Royal College of Surgeons, but unfortunately, it has got postponed. And obviously, we have our annual national meeting, usually attended by about 1,500 surgeons on an annual basis. But friends, then as I took over as the president in February, a problem came all over the world, a tragic year for humanity, and we had to reorient ourselves because most of our activities got changed within a month of the new academic calendar of IAGES. So we very early in March itself, we decided that we will reorient our organization to support COVID warriors, people, physicians who are fighting for COVID, against COVID. And so we had basically two activities for the next 2 months. One was that we started supporting physicians because as you know, India is a vast country and government didn't have reach at many places where surgeons could reach out. And we started supporting these physicians with PPEs, with body bags for dead bodies and masks. And we also started conducting educational webinars for physicians in terms of how to protect themselves, and for surgeons, how to avoid surgeries or how to do emergency surgeries in presence of COVID in their city. And during this period, we also got busy with a lot of research about COVID. So we had the first guidelines for for surgical practice, which already got published. Then we have endoscopic guidelines, which also got published because of the fast forward by the journals. And we had a survey of how the COVID has affected surgeons in India, and which also has got accepted and is due for publication soon. Besides this, IAGES participated in COVID-produced study done by the British group and participated by many organizations worldwide, and this is pending acceptance. We also designed, since the country decided to live with the virus, so resumption and restructuring of surgical practice recommendations, which were designed, and these are also pending acceptance. We also realized that one of the fears among mind of surgeons is about the high mortality seen in patients who undergo emergency surgery and they have COVID thereafter, especially by the study which came from Wuhan, which said about 20% mortality. So we have quickly collected data from about 18 centers in the country for 800 surgeries done in last 2 months, and this data is already being analyzed, and we hope to come out with this data for the benefit of the society, because if the percentage of mortality is not so high, then surgeons can be reassured, and it's a very large multicentric data that we'll be putting out within a fortnight. So friend, this was one. Then we realized that there's a lot of information available for COVID, so we started IAGES masterclass for our general surgeons and surgeons who are doing essential laparoscopic surgery. So the first masterclass happened on 7th June, which was on gallbladder diseases, and the next one is happening on the 28th June, which will be a video masterclass on complications of surgeries, mechanism of injury, and their management. Besides this, we realized that a lot of surgeons and senior surgeons across the world who, for the time being, can come for these webinars and can share their knowledge with us. So we started these international academic collaboratives. The first one was on 11th June on complications of rectal cancer surgery. Today is the 18th June. The next one is on 25th June on weight regain in bariatric surgery, and on 2nd July on distal pancreatectomy, and on 9th July on surgical smoke, myths and aura. So friend, this is how the IAGES has evolved in last 3 months. We are looking forward to welcome you all for World Congress, which is in 2024. Professor Subhash Khanna was there with you when this conference was allotted to us. This is our design and the logo for the conference. And we look forward to see you all soon in India for our national conference next year in Colombo, in Coimbatore, sorry, and then in Kolkata for the World Congress. So thank you very much for patient hearing, and I hand over the mic to Dr. Sunil Popat.
Thank you, Raman. It was a very nice short presentation. I'll share my screen with all of you now. Can you see? Okay. Good.
Yes.
Yeah. So first of all, as Raman has already welcomed, I'm so pleased to be here with this August gathering with my co-moderator, Dr. Randeep Padavan from Delhi. All of you know Professor Barry Salke. He is a mentor to many of us. He is no stranger to IAGES. He has been visiting as a orator, distinguished faculty. He has delivered many prestigious orations in IAGES. He's honorary member of IAGES. And I had the pleasure of hosting him in IAGES 2012 in Ahmedabad, and he operated also in live workshops. Welcome, Dr. Salke. We welcome Professor Eduardo Targarona from Spain, Barcelona, and he is the Chief of Unit GI Surgery in Barcelona. We welcome Dr. Suthet, who is the President of ELSA and a Professor in Department of Surgery. He is a very well-known figure across the laparoscopic surgery fraternities. We welcome Dr. Roy Patankar, the leading GI and laparoscopic surgeon from Mumbai. Dr. Ahmed Nishan, who is Assistant Chief of Unit and Vice President of Laparoscopic Society of Laparoscopic Surgery Society of Maldives. We had a pleasure of being at Maldives last year during a joint conference. We also welcome Dr. Murthy N from Scunthorpe, UK. He is a consultant upper GI and laparoscopic surgeon. He has a very keen interest in GI endoscopy. I am pleased to be having Dr. Randeep Vadavan as a co-moderator, who is a HOD and a senior GI and bariatric minimal access surgeon from Delhi. So friends, we will be discussing about GERD. Why are we discussing about GERD? Why we consider it so important? Because all of you are aware it's a multifactorial disorder. The pathophysiologic components of GERD which can be involved either alone or combined. Defective anti-reflux barrier. Many a time we see mechanically defective lower esophageal sphincter, inappropriate transient LES relaxations, or associated hiatal hernias. May be associated with delayed gastric emptying, impaired esophageal clearance. But as we know, GERD is a chronic disease. Most of these patients are going to require the medicines for a long period of time. Why should we discuss this? Because the progression of GERD, it has been observed 13% of the people have progression over 5 years, and 10% of them progress to Barrett's esophagus, which is a pre-carcinogenic condition. Also, as we are aware, hiatal hernia is a very frequent finding in GERD. So with this beginning, I invite my co-moderator, Dr. Randeep Vadavan, to start with the first of this topic.
Thank you, Sunil, for the introduction. And so without wasting time, let's set the ball rolling. We are fortunate to have esteemed faculty representing all parts of the world. So we need to know what is the prevalence of the disease in their part of the world, and also if the incidence is increasing over the period of time. We know the prevalence is maximum in North America. So we'll start with the question to Professor Barry Salke, and then we'll move forwards. So Professor Barry, what is the prevalence there in your part of the world, and is the incidence of GERD increasing?
It's actually a very hard question to answer completely, because we really truly don't know what the denominator is. You can use several several factors to sort of get a very good guess at it. And that is usually the amount of medications that are being sold by pharmaceutical companies to for people who supposedly have GERD. But you know, that's not a true estimate of it either, because not everybody really gets tested like they should be tested to prove or disprove whether or not they have reflux disease. But I think it's the actual number for me is not so important as it is that it is a real entity, and it is incumbent upon us to be able to discern the patients who really need help with this, especially from a surgical point of view, and the ones that don't need help from this. And that's the key, in my humble opinion. But I think that if to answer, I'm tap dancing a little bit because I'm trying to sideswipe the actual answer. It's around we think it's around a quarter of the population in North America or in the West have symptoms that could be referred to as GERD. Of course, that's a very broad range of people. So it's really an impossible question to answer. It's common, for sure. And we need to be, I'm sure you're going to get into this, of how we just need our help.
Sure. Thank you, Professor Barry. Let's get the answer from Professor Eduardo, and after Professor Eduardo, we'll get the answer from Dr. Murthy. So first, Professor Eduardo, same question. So Professor Barry says about quarter of a population of US is probably suffering from GERD. What's the situation there in your part of the world, in Spain?
Well, I think that my comments should be very parallel in order not to be repeated to the comment of Barry Salke. Probably we don't have maybe the food habits of the youth people, but our habit with our type of food and also with the prevalence of obesity make that really GERD is a very prevalent disease. My opinion, I can only give my opinion as a surgeon. I want to say that probably something in my consideration, but probably we talk later, is that in spite of this large number of people that need IBPs or need medication, there is a very few that go to surgery, and also our standard, our idea of the patient that come for us for consultation, for consideration of surgery, pure reflux has been reduced, and we see much more higher alertness, especially in old people. I want to say that continue to be very prevalent. I think that is related to the food habits of the people. Mostly of them are controlled by IBP, and very few are, and also surgeons, I think that they are very selective to offer surgery because we have other medical options that are very satisfactory. I don't know if I answered, but this is probably my point, my view of the problem from my side.
Thank you, Professor Eduardo. Dr. Murthy, is it any different than Spain that you practice in the UK? Dr. Murthy, are you there with us?
Randeep, I think Dr. Murthy sent a message that he is busy in a surgery. He will join after some time.
All right. So we'll go to Dr. Sutet. So if you see this data here, East Asia is a lot less as compared to the Western world. Both Professor Barry and Professor Eduardo have mentioned, say, about a quarter of their population. What about Thailand?
Thank you very much. Thank you for having me join the panel. My honor. Yes, as we know that the incidence of reflux diseases would be less in the east part of the world. So that's true. I think there are so many factors to be related to these incidents. But anyway, in Thailand, if you have the view on the history, you will see that related to the obesity, you can see that the incidence of reflux is increasing. But the problem is that how to define, how to diagnose the prevalence of GERD diseases. If you use only the symptom, so that might be very high. But if you have some objective, what we have seen in Thailand is about 10 to 15%. But anyway, it depends on what population of the study that you have done. In some specific group might be having increasing to 25%. So, but anyway, it is one of the most important and frequent problem that bring the patient to us, especially for GI symptom, GI medicine or GI surgeon. Thank you.
Thank you, Sutep. So, Dr. Nishan, we hardly have obesity in Maldives, small population. Do you see a lot of patients for GERD, or there are very few and far?
I think, firstly, the notion that we do not have too much obesity is probably incorrect. Our population has recently had a tendency to become obese. And although we are part of Asia, and East Asia has low prevalence for the disease, I believe our population has a larger proportion. I would say from about 25 to a third of our population, 25% to a third of our population is probably having the disease. We do not have any formal data, but from my clinical practice, I would say that yes, a large proportion of the population has symptoms. And this is, I think, mainly because we have very spicy food like India does, and that gives a lot of symptoms. And in addition to that, like I said, we are having an increase in obesity related GERD as well.
Thank you, Dr. Nishan. So, Roy, you can sum it up for us, for India, as well as whatever you've heard from rest of the world.
Randeep, unfortunately, we don't have accurate data from the Indian subcontinent. We do have some early recommendations of the working group of the Indian Society of Gastroenterology. And two things have come out, both from the ISG task force as well as the CMC Valor data. One is the incidence of GERD in a target population in South India has increased substantially. Yes. And the second thing is, unlike the Western data, our patients with low-grade dysplasia in Barrett's don't seem to progress to cancer as much as the Western population. So our recommendations of treatment of high-grade Barrett's may need to be different from those of the West. Those two are the standout points.
Great, Dr. Roy. So we've summed it up very well that it's prevalent all over the world, and no country is spared with it. So it's common, and we see this problem regularly in our OPDs. So Dr. Nishan, what are the common symptoms that you would see, and for the patients that you encounter in your OPD for GERD, and you take them forwards as far as, once you diagnose them from symptoms, go forwards with the investigations?
Yeah, the majority of patients that come to us complain of heartburn. And this is generally after a meal, and the meals are usually very spicy. And despite advising them to have non-spicy food, many continue to have these symptoms. Many also complain of discomfort in the upper abdomen, and some also complain of vomiting. The main complaint here being heartburn.
So any extra esophageal symptoms that you see in your group of patients that you encounter? Esophageal, yes, we know heartburn is probably the commonest, followed by regurgitation. And some patients with unknown cause of chest pain can also come over. And you've also mentioned epigastric pain, the GI symptoms. How about the extra esophageal symptoms?
Very rarely, because our population is a small population, and the number of cases we see are not that many. So extra esophageal symptoms are very rare.
Anything to add there, Sutep?
Thank you. those who have the typical symptom, for example, heartburn or regurgitation or dysphagia, those will come to us as a surgeon or GI doctor. But on the other side, the atypical symptom, as you shown, they may go into our nose or toes ENT colleague, for example, coughing, laryngitis, or the sinusitis, or some of those symptoms. Some of them may complain about sore throat or something, and they try to see this also the problem, or a typical symptom of respiratory symptom. Those also may come and present it to our colleague, or even for chest pain or some arrhythmia would be happening. So these also a patient who are coming with a typical symptom, which they may take times trying to see what gonna be the cause, and finally they may transfer to us to see and to treat for the reflux symptom. Thank you.
Yeah, but most of these patients, like we said, that they come with heartburns. Do these patients directly come to you, or do they go to the gastroenterologist and then refer to you, or do they epigastric pain? I'm sure comes to us. But what about the heartburns and the regurgitation? Do they come to you, or are they referred from the gastro guys?
Good questions, and I think the people it depend on the institute. For example, in our centers, those will come directly to our gastroenterologists mostly, because we know that the treatment of the reflux might be going to the medical treatment or lifestyle modification. But anyway, if they are qualifying to do the surgery, or they are beneficial from the operation, they will transfer to us. But a small number of cases, they may come to us as a upper GI surgeon directly, because they know, they learn, and then they research, they may come directly to us. But the treatment would be not different between going to gastroenterology or coming to us.
Thank you. Thank you, Sutep. Next slide, please.
Okay, so after listening to the learned faculties about the symptomatology and the incidence and prevalence, what we need to discuss is how do we diagnose. Now, the investigations are for two reasons. First is to diagnose the GERD, and second is to do the investigations pre-operatively. So we being surgeon, we are called for when the gastroenterologist physician is thinking about the role of surgery. So we think like surgeon, but practically the investigations, I would like to start with Barry. Barry, what would be your investigation protocol?
Thank you very much. I'm looking at your slide, and I would agree with that in general. I think everybody knows that endoscopy would be the first thing that we would see in terms of trying to make that diagnosis. But it's not only you got to remember also, it's not a visual diagnosis. You need, excuse me, microscopic evidence of effect on the esophagus from reflux. So they should be biopsied, even if it looks normal. And what that would be the first thing. And of course, most of us are clinical surgeons, so we go on clinically what the patient is telling us in terms of what their symptoms are. Not every place has the ability to do impedance pH monitoring or standard pH monitoring for that matter. And it's important to keep that in the back of your mind, because on the very difficult cases, the ones that aren't typical symptoms, the typical relief from medical treatment, and especially the ones who have extra esophageal symptoms, will need impedance monitoring. I think probably of all the things that I see in here, the most important thing is for us to be able to differentiate real reflux from other things that cause symptoms like reflux, because the worst thing that can happen as a surgeon is that you do this beautiful operation for the wrong reason, because you will have an albatross around your neck for the rest of that patient's life and maybe even the rest of your life. So it's really, really important that we be able to differentiate those things. And all the things you have listed here are appropriate.
Yeah. So I'll go to next slide. And as Roy is a very close friend, I know he's doing a lot of endoscopies. So Roy, what would you be looking for in upper GI endoscopy when you are diagnosing a GERD patient?
So I'm looking for the Z line, I'm looking for esophagitis, I'm looking for a Barrett segment. And if I see Barrett's, I would certainly do a narrowband imaging. I want to look for if there is any stricture. I want to have two clear lines that I see to quantitate the hiatus, if any. I also want to do a J position to make sure that I'm not missing something from within the fundus. So this is a nice sliding hiatus hernia, Sunil, which has got probably a LA grade C esophagitis. I would certainly biopsy this to be certain of what I'm doing. I would complete the examination by making sure there is no gastritis or gastric stasis, go up to the second part of the duodenum, and only then call the procedure complete. And for me, a narrowband imaging is part of any upper GI endoscopy when I suspect the Barrett's. May I just add one more thing? For a revisional surgery, I would not do a barium videogram. I would rather do a good contrast CT, because I want to see the amount of herniated wrap in the chest. And unless I have adequate data on the crural distance and the amount of herniation of the wrap in the chest, I don't think a barium gives me as much information. So for me, a CT would replace a barium in your flow chart.
Yeah. So when would you do barium, or you wouldn't do barium follow-up?
Bariums only when I seriously suspect a shortened esophagus, when the patient has had a peptic stricture which has been repeatedly dilated, or I suspect that I may have to do a esophageal lengthening cholecyst gastroplasty. But that will be after a CT. I would never do a barium just before surgery.
Okay. That was good. So all of us are quite aware regarding LA classification grade A, B, C, D, and I'm not going to detail it. We all are aware. What is important is when we discuss the surgery, it will be important to see. I move on to the next question regarding the 24-hour pH study. Professor Eduardo, in your institution, what is the protocol and how much you rely on pH studies? And in your opinion as an upper GI surgeon, what is the importance of 24-hour pH study?
Our protocol usually, first of all, is the flexible endoscopy, obviously. I also I like, especially in the case that is pure reflux without hernia, is to make a manometry. I think the manometry is very, very especially important for, especially if there is some problems after surgery. You need to have the reference, and the pHimetry. We are very selective at the hospital. Usually, we try to perform routinely the three examinations: flexible endoscopy, manometry, and pHimetry. However, from the practical point of view, I think that the pHimetry should be only. I think that's very specific, has been commented before, in the case with extraesophageal manifestation of the reflux, that really you need to identify the existence of the reflux. If you found in a flexible endoscopy a clear esophagitis and the biopsy is positive, many times you can avoid the pHimetry. However, I think that is a maneuver that should be taken, especially when you have some difficult cases, some not clear cases. I would like, because I learned from him, but I would like to reinforce the concept that Barry Salke proposed before. I think that the patient should be sent to the operating room very well studied, because it's nothing more disastrous than operating a patient that has not a clear indication. In summary, flexible endoscopy, manometry for most of them, and selectively the pHimetry. Maybe it's different in the case of the big hernia that maybe we talk later. But at least in this situation is for the pure reflux. Usually we don't use CT scan or videogram preoperatively for many years. We rely in the flexible endoscopy for the pure reflux patient.
Okay. So before I go to other faculties, I would like to hear from you regarding manometry. What you are looking for in manometry in the case of reflux?
Manometry, the most important is the pressure of the pressure of the lower sphincter to know really that there is an incompetent sphincter, and also that the waves of the esophagus are correct, or maybe some slightly malfunction. I have a special interest in manometry because I have had experience in 2 or 3 cases of patients diagnosed of reflux that they were early achalasia. Early patients with achalasia may have reflux, may have a light dysphagia, and you operate the patient, you have a problem. And then really, you obviously you need to have a very, very dedicated interview to the patient. And if you have any doubt, I think that the manometry is a very quick exploration that gives to you a lot of information. And also it's interesting in the case of if you have problems after surgery. There is about the 20%, 15-20% of patients that will fail or more, that maybe some of them will need to be reparated. And I think that is a good reference to have a previous manometry.
Do you actually ask? Yeah, just a minute. Eduardo, do you actually ask for pressures of esophageal body? How much the pressure is, or contractile amplitude?
Sorry, I don't understand.
Do you actually ask for the pressures of the esophageal body contraction from your GI physician colleague who is doing the manometry?
Sorry, I don't understand the question.
Okay.
Sorry.
I'll go to Roy. Roy, I know you have a very good protocol-based policy at your institute regarding doing pH and manometry in almost all cases. So, what is your opinion regarding pH and manometry?
So I agree with Professor Eduardo that a pH study we would do only if the diagnosis of GERD is in doubt, say endoscopy negative reflux or somebody with atypical symptoms. A typical refluxer doesn't need a pH. The esophageal manometry will give you 2 things. One is the LES pressure. So a normotensive or a hypertensive LES should be a red flag for you. The second is we give them 10 wet swallows on a high resolution manometry and see the progression of the propulsive wave. I do it basically to rule out patients, like Professor Eduardo said, as early achalasia I can present with heartburn only. So one is to decide whether to operate on the patient. The second is to decide, I know this is controversial, but we decide the type of the wrap based on the clinical symptoms and the propulsive peristaltic wave of the patient. The third point I want to make is for large paraesophageal hernias, esophageal manometry may not be helpful because placing the catheter may be a job in these large PHs.
Yeah, right. Barry, you want to add anything to this regarding pH and manometry?
Yeah, I'd like to add one thing. I think what Eduardo said is very, very important and should not be passed over lightly. And I would not operate on someone with extraesophageal manifestations of GERD without having a 100% complete workup. So that means that if you're in an area that you don't have manometry, or you don't have pH, or you don't have impedance study, that you must send that patient out to get evaluated completely before you operate. I think that is really, really key. And I would say it goes triple if you're beginning to think about operating on someone who has reflux or who has laryngitis type symptoms, ear, nose, and throat symptoms, especially. I think it's a big mistake to operate on any patient without a complete workup on that. We can always discuss the indications for surgery on symptomatic GERD. I mean, it's a never-ending discussion for sure, right, because everybody thinks they're right when someone has a symptom. It's treated with medication. The patients get better, and you say, "Aha, that patient has reflux." It's not always the case. You must have other objective data to show it. And I would say if you're not going to do 24-hour pH and manometry, those patients better have grade 3 or grade 4 esophagitis on endoscopy. Otherwise, I think you're making a mistake to operate on those patients.
Yeah. Second thing is when you have a patient who is already on PPI, so what will you subject to them? How will you advise them for pH metry?
Yeah, well, listen, they're all on PPIs. And I mean, the first response that we see is that they have a response. If they don't have a response, they need to be worked up completely, 100%. Otherwise, you're making a big mistake. So, you know, I understand that it's difficult to work up everybody, and I understand that there are places where you can't work up everybody, but I think we have to do the best we can to make sure that you're doing the right operation for the right reason.
Yeah. So there is also some evidence suggesting that if the patient is on PPI and the patient cannot stop PPI for a couple of weeks prior to pH study, you go for impedance pH study. And if the patient can stop PPI, then you wait for 2 weeks and then go for regular pH study. Do you agree with that statement?
Yes and no, because I think everybody with reflux, to use 2 weeks as the cutoff is very arbitrary, because I don't remember a patient who could come off PPI with real reflux, who could come off PPIs in 2 weeks. They all have symptoms. And you know, we now have, pharmaceutical industry has a variety of different PPIs, so they all go through the sequencing of taking stronger and stronger PPIs or different types of mechanisms. I think that the most important thing is that we as surgeons understand that not everybody is going to fit the definition that we think that they should when they have reflux. So be very, very careful about selecting the patients for surgery. Okay,
good. And any space for barium swallow in your practice?
Mainly if it's if the endoscopy shows that it's a short esophagus. I wouldn't argue the fact that CT gives you a great view of the relationship of the esophagus to the diaphragm and the abdomen. That's really its advantage. You can see both of them all together, which really is very, very helpful. But sometimes it's hard to get CT scans, or they're busy, or whatever. They are more expensive. So a barium swallow I would say, it's old style, but it does give you information.
Yeah. And there is a suggestion that in a case where you are suspecting eventration or say transmediastinal migration of the rep, it is better to do the barium swallow in a standing position, but not at all the places this facility may be available. But where available, it is a good thing to do. So I will come back to you regarding when do you think it is required to do gastric emptying study?
Talking to me?
No, Roy.
I would do a gastric emptying study selectively if the patient has a history of upper abdominal bloating, because these are the guys who are going to give you trouble after surgery. So only if they have an upper abdominal bloat as part of their symptomatology, I would do and I would do it for solids and liquids. To be honest, I'm more concerned about patients with large paraesophageal hernias, the elderly patients. They may have a concomitant issue of gastric emptying as well, which we need to counsel the patient beforehand.
Good. Eduardo, any further comment?
No, I think that at least I was thinking about in our workup of the patient. Usually, we don't not pay attention to the risk of. I think that the difficult to empty the stomach is another disease, maybe it's another problem. But in the context of reflux, I don't have too much interest to explore it, unless the patient has really a bloating symptoms, or maybe diabetics, or very post-operative patients. But in the workup of the pure reflux, I don't see a special interest from my point of view.
Okay, thank you. So over to Randeep.
Yeah, so once we've diagnosed that yes, there is a reflux and the patient requires a treatment, of course, we start with the medical treatment. So, Professor Barry, we know what we do. We start with the medical treatment. The PPI is a first-line medication. What else do you want to add in this patient who's been diagnosed as GERD and comes to you, and you want to start with the medical treatment here?
Keep forgetting to unmute. Sorry. Well, I guess it really kind of depends on every patient's a little bit different, and it depends on what they've been treated with before and exactly what their symptoms are to begin with. The medical therapy is quite sophisticated nowadays, I would say, for sure. And it's really, I think, unusual to have a patient who doesn't have at least some response to medical therapy, assuming they have GERD. You know, I mean, that's the assumption. Of course, if they don't respond to PPI, that sets up a whole cascade of other testing that has to be done. I mean, listen, there are pro-motility agents. And probably the most important thing is lifestyle changes. But we know that that's very, very hard for patients to accept and to change their way that they're used to living their life. And it includes everything from alcohol, spicy foods, smoking, you know, obesity, you know, the whole realm that we have to deal with. Very hard question to answer. I mean, I'd like to hear what some of the other experts have to say about it.
Yeah, so Sutep, Professor Barry just mentioned that lifestyle dietary modifications need to be done. Of course, they do help and they will help, but we do add the PPIs. Do you add, apart from the PPIs, like the H2 receptor antagonists or pro-motility drugs as treatment, and you do all that?
Thank you. I do agree with Professor Salgi that lifestyle modification is the must. Secondly, most of the patient would go to PPI. But anyway, the H2 antagonist or other, even the Sucalfate is also working very well for some patient. And that's it, those you may or a patient may try, because the aim of the treatment of the reflux is to treat the symptom. How to treat the symptom? Mostly you have to reduce the acidity of the reflux content. So that's why those medication would work. Lastly, the prokinetic drug, I may think that those medication might be added at the end if after having PPI or those medication, but the patient still having some symptom, you may add the prokinetic drug for the patient.
Okay, so let's say the patient is responding to the medication. You continue with the drugs and the same regimen. And how often would you like to do, endoscopy or any investigation in between to find out if these patients are not moving on to developing Barrett's or any other problem?
I may prescribe the patient to have the endoscopy done if the symptoms still persist, even with trying to add medication or increase the dosage of the medication. Or secondly, you seem not to be respond to the medication and you plan to do the anti-reflux procedure. So those need to be under, again, the re-investigation. Lastly, if the patient does well with the medication, I think you may need to surveillance the patient, for example, yearly endoscopy, not only for the reflux, but those for other reasons too.
Okay. So, Dr. Ahmed, you mentioned that you've got a lot of obesity in Maldives. At least the incidence of obesity is increasing. You also mentioned that there's the diet has changed. A lot of people take spicy food, or most of the people take spicy food. So what is the lifestyle modification you would advise to these patients when they come in, apart from starting them on the PPIs?
Yeah, thank you. So our very first recommendation is usually to avoid spicy and oily food. Our food includes a lot of chilies, and we have to ask them to reduce that. And we also ask them to reduce large meals. And like it was mentioned earlier, alcohol is also a problem, but in our setting, alcohol is not so much of a problem, although smoking is. So we ask them to avoid smoking as well. And ask them to avoid lying down or sleeping immediately after meals, to give a break of about 2 to 3 hours, and to elevate the head end of the bed or place where they're sleeping.
So what we've seen, there is in GERD, what we find is there is a transient a relaxation of the LES, which increases. And what we've seen is primarily, as per, if you go down all this list, you'll find that fats kind of increase the transient increase in the transient LES relaxations, as well as smoking does. So those are two things which you need to be very careful about. Fats in particular, fats, particularly when you're talking about dinners, do you generally advise them, to have early dinners and avoid fats during dinners or anything like this?
Overall, we ask them to reduce fat in their meals. Do not specifically mention dinners. But yes, dinner is a meal that has to be taken a lot earlier to give a break between meal time and sleeping time. So yes.
But if you look at this data here, this data is clear that there is no evidence actually to suggest that caffeine or spicy food or citrus food or carbonated beverages will actually increase GERD. But yes, some people taking a particular diet may be prone to developing GERD, so they are told to avoid that. But generally, we see there's no evidence to suggest that.
Yes, but a lot of patients come back to us and say that it's easier for them when they do not take these kinds of foods.
Sure. Next slide, please.
Okay, so we discussed about the medical treatment, and I would come back to Dr. Nishan, that what are your preference for PPI or proton pump inhibitor treatment?
Yeah, we generally give PPIs that's for long term, and along with a short term course of an antacid. The general ones we use pantoprazole and esomeprazole because it's easily available and not very expensive.
Okay. Dr. Sutep, what are your preferences and how will you go about it, PPI treatment?
Yeah, most of the patients would go with a PPI, and most of them would be doing very well with a PPI. For the preferences depend, I think, for me, no specific of the PPI, but the doses of the PPI, that is the more important for me. We start with a regular one, and if they are not doing well, we can double the doses and we follow the patient. So, and also the PPI responsibility to the treatment, I think that also would be the definition for failure of the treatment in our center.
Okay. Okay, Eduardo, what is your advice regarding PPI treatment to your patients?
Well, absolutely. I think that the treatment of reflux is a mixture. You commented the lifestyle and also drugs. I understand at this moment that omeprazole is the most important. It's really a very efficacious treatment, and there is a big spectrum of patients. There is the patient that really with one pill and reduce the symptoms, to the other people that really needs to be maintained in more than 40 milligrams per day, or in spite of the PPI have a lot of symptoms, for example, regurgitation, on that it avoids a social life. My feeling is that all the patients with reflux, we began with PPI. I understand that PPI is like a pachymetry. The patient that responds to the PPI, that means that it has really a reflux disease. And then most of these patients are controlled by the gastroenterologist. And usually my indication in relation to PPI is between patients that need continuously a high dose, that has been some complication, for example, that have a barrier, that have a very severe symptoms in spite of PPI, and people that need to be operated. I continue thinking that the gastroenterologists maintain many patients with large doses of PPI because they don't rely on surgeons. Probably these patients need to be sent to the surgeon, especially for patients that that they need for the whole life. Young people that have a disease that is based on responding to the PPIs. I think it's a surgical indication because they will need the whole life maintain this drug, and it seems that this drug also have some complications. Then I understand that is a wonderful drug, but we need to pick the patient that is better to be operated.
Yeah, absolutely. You raised a nice noise regarding the side effects of PPI. Many people think that there are no side effects. There are side effects if the patient is continuously taking for long term. So, Seth, what is your opinion about that?
Yes, any medication would have some side effects for sure. For example, you can see from your slide that there are diseases, especially when you reduce the acid for the long term, that also would lead to the side effect. You can see PPI itself with the very low of the pH, very low acidity in the stomach, that also may lead for long term, but we don't have the strong evidence to support that might have some problem. But for sure, we do have the evidence that PPI may lead to, for example, diarrhea or headache or abdominal pain, nausea or abdominal pain. This is all the side effect that we do need to discuss with the patient. But for long term, yes, we have to try to see, or the evidence, strong evidence to see what is the drawback of using long-term PPI.
Yeah, absolutely. And some patients do get osteoporosis and some fractures and also community-acquired pneumonia. So it's a wonderful drug, but it is not without side effects. One has to continue taking it under the supervision.
Yes, so we come to, the patients are not responding to PPIs. What do you do next? It's a refractory GERD. So how do you manage these patients going forwards, Roy?
So Randeep, when I first look very carefully at the symptoms of the patient, his investigations and his compliance with the PPI regimen, has he taken a double dose PPI? Have they been taken before meals? Before I can really call it refractory GERD. So one, is it refractory GERD or is a symptom suggest to a refractory GERD? I need to separate those two groups in my mind. I would get these patients off PPI for 10 days, do a 24-hour pH and a manometry and repeat upper GI endoscopy before I call it a refractory GERD. Refractory GERD is a minefield. I think most people would agree that operating on refractory GERD should be done with a great deal of caution. We have a small experience with reasonably good results for doing a partial wrap in these patients, but this is a minefield. Please be very, very careful. First is confirm it's really GERD, look at patient's compliance, and then investigate the patient yourself thoroughly to convince yourself there is no associated irritable bowel syndrome, there is no psychological problems, there are no motility issues before labeling them refractory GERD.
Okay, so right. So what you've mentioned is drug compliance need to be seen. There could be other issues as well. So you've actually done a manometry, you've done an upper GI endoscopy, and you've done a pH metry after stopping anti-secretory drugs for a period of 7 days or 10 days, as you mentioned, and the patient turns out to be a case of GERD. What do you do next?
Is that for me?
That's correct.
Randeep, in that case, with a great deal of counseling, after I convinced myself there are no concomitant GI issues or psychological issues, I would take a consent explaining to the patient that he may not get 100% relief. Let the patient earn his operation. Don't be in a hurry to push it down his throat. In carefully selected patients, there is a large study in gut which clearly shows that a partial wrap for carefully selected refractory GERDs can have good results. But be very careful of this group.
Professor Eduardo, so this is a question for you. So let's say the patient was already on a PPI, was not responding to PPI, was a refractory GERD. Would you consider adding something like, which increases the or decreases the LES, transient LES relaxation, or increases the LES pressure, something like a baclofen, and then probably take it forwards? Or would you consider investigating the patient completely?
No, I really, this is a very difficult patient, and you need to be very careful. And really, sometimes as a surgeon, when there is as a surgeon, I consider for surgery only absolutely clear cases. The cases that they are not clear, I think that you need to complete workup, also to talk and to analyze exactly the symptoms, because many of the reasons of this kind of refractory GERD, the problem is that the patient has another disease. And by example, eosinophilic esophagitis, impaired gastric emptying, etc., then you need really to check really if this is a non-responding GERD. Non-responding GERD, it means people that continues to have reflux and heartburn. I think that for me is the most important, and regurgitation. And obviously, these patients should be treated with medical treatment, also with facilitation of the emptying of the stomach, maybe in the case of the esophagitis with steroids, etc. And sometimes you need to talk with the gastroenterologist and to reject this patient for surgery. I want to say that my final consideration is if I don't see clear the patient, I prefer to avoid surgery.
Thank you, Professor Eduardo. So welcome, Dr. Murthy. He was operating. He's just joined us. Welcome to the webinar. So this question goes straight to you, Dr. Murthy. This is the algorithm which has been published. Most of it has already been mentioned by Dr. Roy and Eduardo. Anything else you want to mention here when we are when we look at refractory GERD?
I'll show you something which is pretty much self-explanatory. There you go. That was my last refractory GERD. This lady, we sent her for high resolution manometry, and turns out she is completely aperistaltic, and she has an esophageal dysmotility disorder. She was not wearing it. My suspicion was achalasia, but there was normal inhibition of peristalsis. No liquid, no rapid, no solid, no bread, nothing went down. It's all just sitting there, one big blur.
Great. So, yeah, this is what we discussed earlier, that complete investigations need to be done before the patient is advised the procedure or advised treatment. And this is what was emphasized earlier as well by Professor Barry, as well as Professor Eduardo and Roy and everyone else, that complete investigations, including manometry, needs to be done. So probably which wasn't done, and that's why the refractory GERD was labeled there. Yeah, correct. Next slide, please. So coming to Barrett's esophagus, since you've just joined us, Dr. Murthy, so what's your take on Barrett's esophagus? You do an endoscopy, you find there's a Barrett's esophagus. How do you take this forwards?
So our system is simple. We offer them all the options. One thing that is guaranteed offered to all these patients is Barrett surveillance program. They get into surveillance program based on the extent of dysplasia and presence or absence of intestinal metaplasia, which is the necessary criteria. Then they get option to have further investigations in terms of barium swallow and high resolution manometry with 24 hours impedance pH studies. Now, if they have objective reflux, and if they choose to, they can get a surgical option. If they have dysplasia, they get option for radiofrequency ablation or
photodynamic therapy. That's what we currently offer. Cryo, we are not offering in our center at the minute, but everything else is on offer for these patients.
So what is your surveillance regimen that you follow? How often and how frequently do you do the endoscopies?
So again, surveillance regimen is BSG, Barrett surveillance regimen.
Okay.
So, what I'll do is I'll just share this British Society of Gastroenterology resource, and we stick to the Barrett surveillance regimen. Let me just share this. So this is the BSG. So majority of the patients, as per this regimen, consensus regimen, they have intestinal metaplasia without any dysplasia. There's a nice chart here. So this is what we are required to label. If there is any definitive intestinal metaplasia in the previous one, if there was ever low-grade or high-grade dysplasia, and if there are any ulcers, if there are any strictures, and if there are any nodules. If none of the above, then it goes into the standard protocol, and this is the guideline. This is what we normally do. So we repeat OGD every 3 to 5 years if there is less than 3 centimeters intestinal metaplasia. If it is longer, then it goes more frequently, about 2 years. For most of the dysplasias, we offer them RFA or photodynamic therapy. And if they choose not to, and if they choose to continue on surveillance protocol, then what we do is we do annual surveillance of low-grade dysplasia. High-grade dysplasia or indeterminate goes straight to multidisciplinary team meeting and is treated as cancer unless until proved otherwise. Presence of ulcers, presence of nodularity, irrespective of the pathology, is taken to MDT because it is still treated as a esophageal cancer. Now, majority of them, the MDT discussion, at least in our network, is to get an endoscopic ultrasound to assess the esophageal wall, and they may actually choose to take microcourse. The microcore biopsy for further evaluation.
Great. So when do you offer them, when moving on from medical treatment to a surgical treatment, or offering them a fundoplication, or is there any data to suggest that if you offer them fundoplication, there is a resolution of resolution of Barrett's?
So again, there is adequate data, which I won't keep disturbing you. I've got all the data brought about. So there is adequate data to show procedure, or whether you offer them. Can you hear me?
Yeah, we can hear you, Dr. Please just continue. Yeah, please.
Yeah, if you offered them long-term PPI, it's supposed to help with GERD, and it's supposed to decrease the extent of mucosal damage that happens as a result of protracted acid or alkali exposure, bile exposure. There is adequate evidence to show that an anti-reflux procedure is useful in this situation, but the patients are counseled to advise them that they will still go ahead and have endoscopic surveillance as per the protocol till the biopsies come back negative. Till represented positively identified biopsies of gastroesophageal junction come back as negative.
Sure, thank you. Next slide, please.
Okay, Dr. Murthy. Hello.
Randeep, can I make a point?
Yes, please,
Yeah.
Dr. Ramek, please. carry on.
I think we need to look at this a little bit cautiously because we have a very robust data from the Indian subcontinent saying that our high-grade dysplasias don't seem to progress to adenocarcinomas like they do in the West. So high-grade dysplasia in the Indian subcontinent can be quite safely managed with endoscopic surveillance. Number two, I am unconvinced that radiofrequency or photodynamic therapy has been shown to prevent cancer, and they still need endoscopic surveillance. We need to take into account cost of these procedures, the cost of a regular endoscopic surveillance in our country. Thirdly, before we accept the IAGES recommendations, most surgeons in North America or Europe don't have domperidone. And we have quite robust data from Uday Goshal's group in SGPGI saying that for volume refluxes, addition of domperidone to proton pump blockers for 3 to 6 weeks is quite beneficial. Just a little bit of 2 pennies worth.
Wonderful, wonderful. Great points.
Okay. So welcome, Dr. Murthy. We missed you in the earlier part, but we'll definitely catch up with you. So we move on to the indications for anti-reflux surgery. I have been getting many questions from the audience that what are the indications for anti-reflux surgery? So I'll go first to Dr. Murthy as he has joined late. Murthy, in your practice, what are your indications for surgery?
So the single largest indication for anti-reflux surgery is patients' request for one having established a surgically treatable disease. So surgically treatable disease, as defined in NICE guidance, I can share this NICE guidance here. Let me see.
Just what do you think whenever you see a patient in your outpatient, when would you consider the patient for surgery?
So when do we consider patients for surgery? When they have symptomatic GERD, when it is when there is distal esophagitis, when there is HRM and 24-hour impedance proven reflux with symptom correlation and with a good symptom index, and then advise the patient that this can be treated with alternate methods, medically managed with PPIs. Then there are endoscopic managements, and then the third one is surgical management, and give them choice with all the information. They go away, think about it, come back and tell us if they want it. If they want it, we go ahead and do it. But what they need to do is they need to understand the risk profile, whatever the complication profile that comes with a lifestyle material. The most common one in our practice seems to be gas bloat. And if they understand the concept of gas bloat, they will go ahead and have the surgery.
Okay. Eduardo, in your practice, when would you say that you require surgery to the patient?
Sorry, repeat. I didn't.
In your practice, what is the indication for anti-reflux surgery?
An indication clearly what the patient that is a symptomatic patient that responds to anti-reflux medication. Also that it has no perfect control with this kind of medication. That means that when he's out of medication, he has symptoms. There is also young people, especially young people with severe disease, and also obviously extra esophageal reflux-related complications. There is a lot of patients that want to improve his quality of life, that they want to be out of the medication, and that prefer maybe the complication of surgery than the quality of life that they have with a daily reflux. I absolutely agree with that. You need to inform very well the patient. I think maybe we talk about surgery. I think that Nissen is a wonderful operation, but also could be a very bad card of presentation. The patient should know that he will have new symptoms, but the reflux will be cured in a lot of patients.
Okay. So let me ask the same question in another way. When would you not operate? Symptomatic GERD patient, when would you not operate?
It's to me?
When will you not operate a GERD patient for anti-reflux surgery?
Sorry, it's difficult to be understood. Maybe there is some noise. You can repeat?
Okay. Is there any patient you would not operate for anti-reflux surgery?
Any reason to not operate?
Any patient you would not operate for anti-reflux surgery?
Yeah, the patient that you have not a clear, that not have a clear symptom. But for me, the most important is the symptomatology of the patient. If the patient is not have a clear indication, I avoid that. I consider that the patient, that this operation should be only indicated in the right patient, and the selection of the patient is very important.
Very good. Any patient who is not responding to PPIs, you would think twice before operating on those patients. Barry, may I come to you now that in your practice, the indications for anti-reflux surgery?
Sure. Well, you can. Okay, can you hear me?
Yeah.
Great. All right. So that is the crux of the whole issue with surgeons and reflux. Very easy to ask the question. The answer is not so easy. So number one, for me, let's take the easy one. For reflux, that for patients who have symptoms of reflux, but they don't respond to anything, that's a big red flag. A big red flag, and that includes using a partial fundoplication. For me, I would not do that on those patients. Number two, I can't remember a patient where the indication has been solely Barrett's esophagus, because I think that, as has been said, the is not exactly strong to say that doing an anti-reflux operation will reverse Barrett's esophagus and will prevent the progression of cancer. I know that there are cases where it does do that, but it's not consistent. So for me, that's not an indication. I'm with Eduardo in that the vast majority of patients who I'm going to operate have symptoms that have really affected their life. And this is a lifestyle changing operation. When done for the right indications, the patients are incredibly helped. Their life changes, and it's all positive. I don't think that any of us can do that 100% of the time. It's just one of those things that you can't be 100% sure of all of the time. But we should do our best to make sure that those symptoms, that those patients, the symptoms correlate. You have objective data, endoscopy, motility, manometry, impedance, all the things that you really need to correlate to a good result. And if you do that, then your patients are going to be very, very happy, and you're going to be very, very happy. But if you don't do that and you begin to cut corners, then you're going to have some patients that it's not going to be a good thing.
Absolutely. In other words, patients most likely to have successful outcomes are the typical symptomatic patient with GERD, heartburn, and reflux, who have given good response to proton pump inhibitors. And on pH study, they have seen increased esophageal acid exposure. Now, Barry, would you come across a patient who is referred to you by your physician colleague who has not responded to PPI, and still they are insisting that, sir, please operate, do something for this patient?
Yes, the answer is I do get some of those patients. I try not to operate on those patients. I think in my younger days, before the beard and when I had hair, I did operate on some of those patients, and I was not very happy with the result. And the patient was not very happy with the result, even though you explain to the patient that the results may not be 100% and that there may be problems afterwards. So I think as I got older, I understand the disease a lot better. and I became very, very selective of who I operated on and who I did not. I would be very careful of the one who's refractory, that they don't have an answer for, because if the medical person doesn't have an answer for, you, the surgeon's not going to have an answer for either.
Yeah, absolutely. Eduardo, you agree with that?
Yes, absolutely. I commented before. Obviously, also something. Sometimes to understand the symptoms of the patient could be not easy. If for that also that you have the pachymetry, the manometry. Obviously, if you have a patient that has esophagitis, has a pathological pachymetry, has a manometry with a low pressure sphincter, but the patient doesn't have a clear response to the PPIs, this patient probably needs to be operated because it is a matter of communication. But I want to say that I agree with the concept of Barusalki. There is a very difficult patient, the patient that has a manometry that is not absolutely sure, pachymetry that is normal, the patient that explains some strain, some difficult answer to the medication. I prefer this patient to keep out of surgery for sure.
Right, absolutely. So surgeon has to learn how and when to say no for this surgery to have the best possible candidates for the best possible results. Now we have received one question from the audience. Is there any role of Ida Stan in a case of reflux?
No.
No. Murthy?
Yeah, so people have done a lot of work on gastroparesis. People have done a lot of work on esophageal motility. They have done lots of radionuclide scanning, this, that, and the other. Long and short of it is no. There are absolute contraindications in my view, and IAGES basically gives them as some of the 5 criteria, and doing a scan to find them is futile. So there is no role for HIDA scan, although some studies and the enthusiasts want to use it.
Okay, good. Randeep?
So I can't see the slide which is going is the Barrett's. So you've not moved the slide?
No, we have moved. It is GERD choice of surgery. What slide you are seeing?
I'm seeing the Barrett's esophagus one. Not,
what everybody else is saying.
We're seeing Barrett's as well.
Okay. So I am sharing it.
You need to share your screen, sir. What we'll do is we'll continue with the question. You said choice of procedure is the next one, correct? So Sutep, coming to you, what would be your choice of procedure? What would be your first choice procedure?
Can you see it now?
Yes, we can. So yeah, so we are right on the slide, choice of surgery. So Sutep, what would be your choice of procedure?
Thank you. Now it's coming to our,
domain.
Territory, our domain, yes. After having all tests done, I think that would help us very much to design for the procedure. So what we would like to do is that to treat the patient. So the reduction, if the patient does have the higher hernia, of course, we need to go in and do the reduction of the higher hernia and also social of the hiatus. Finally, we have to design the part of the fundoplication, which is very important too. So if you ask me what I would like to do before, I would love to do the manometry. This is very important for the decision making during the procedure. So mostly of my patients would go with Nissen Fundoplication, but except those who does have some motility defects of the esophagus, those patients may do partial fundoplication. So this is the protocol that I'm doing.
So you'll by and large follow what the choice of surgeries are there in this slide. So if it's a normal esophagus length motility, you would go in for a 360-degree Nissen's. if there is a motility disorder which you've actually seen, you would go for a partial fundoplication, correct?
Yeah, that's right.
So
And also the last one, you're right. It's for obesity, of course. What my choice would be lumen gastric bypass.
anything different, Dr. Nishan? You would do anything different than what is suggested here?
No, I think this is what we would follow. The numbers we have is very less, and the surgeries that we do are Nissen Fundoplication.
Roy, anything different than what is suggested here?
As usual, I have a little point of view which is different.
Sure,
I think age for me is an important criteria. I would not do a Nissen's for an elderly person about 60 years of age. The second thing we have is anybody with any atypical symptoms. Even the slightest hint of atypical symptoms in my book would be a toupees. I think 10 years ago, if you'd asked me this question, 90% of the fundoplications we do would have been Nissens. Right now, it's about 40% and 60% are toupees. And length, motility, atypical symptoms, and age are the 4 criteria I decide.
Exactly, and that's what the data is coming around. In fact, if you look at the latest data published just a few months back, a systemic review, it says the same. So by and large, people are shifting more towards toupee rather than. So this was published just a couple of months back, a systemic review where they compared various procedures, and they found that with a fundoply with a 360-degree Nissens, there was a 2.6-fold increase odds for dysphagia as compared to the other procedures. Gas bloats were, of course, again more in 360-degree fundoplication. Next, please. And PPIs, of course, any of the fundoplication works a lot better than the PPIs in the long term, and no difference across treatments where it found to morbidity or reoperations with comparing a toupees with a 360, and they concluded that probably in almost all scenarios, probably a toupee would be a better option than a 360-degree Nissens. So what's your opinion, Professor Barry, since you've been involved with this right from the beginning? You would have done huge amount of Nissens and toupees and all the procedures. What's your procedure of choice as of today?
You ask a very, very good question. I've changed a little bit as I've gotten older. I think that this, you're correct in that a partial fundoplication, I never did 180, I only did 270 degrees, seems to have less postoperative symptomatology. However, I think what you're really getting into are the technical aspects of doing a fundoplication. And I especially mean the length of it and how tight one makes the fundoplication. We all know that we all talk about loose, floppy Nissen fundoplications, but that loose, floppy fundoplication in everybody's eyes is a little bit different. And the healing process in patients is a little bit different in everyone. So sometimes you think it's nice and loose, and in the end, it's very, very tight. I think most of the patients, if they're below for me, the age is also an indication for me in terms of the types of indication I'm going to get, types of fundoplication I'm going to do. If they're over the age 65, even if they have normal motility, I almost hold on once. Sorry, I have my grandchildren in the room. All of a sudden, they woke up.
Fine. They're keeping the atmosphere light.
Their own indications. So let me say, if they're over the age of 65, I never do a Nissen fundoplication. I have found over the years that they have many more symptoms. So age is a cutoff for me. That's number one. Number two, my preference, especially if they're younger, is a very loose Nissen fundoplication. That's what I would do. I still, if anybody has any symptoms of any dysphagia and the motility looks okay, I'm going to do a partial fundoplication because I think the postoperative symptoms tend to be much more acute in those patients. everybody has dysphagia postoperatively, even in partial fundoplications. It's just a length that it's going to happen postoperatively. So you have to tell your patients and make sure they understand after you've told them that they're going to have dysphagia after the operation, no matter what you do. If you do that, then I think you can't be strong one way or the other. You have to have some ability to change the type of operation depending on the symptoms. That's for me. That's what I would do. And I'm not talking about paraesophageal hernias. That's a different situation.
Sure.
If we're going to get to paraesophageals, we'll do it a little bit different.
Sure, sure. Thank you. Yeah, so I'm pretty much.
I would like to comment.
Yes, Professor Eduardo.
I not completely agree. I think that we're talking about, that's true, that probably, that's for sure, that Nissen is an overpowered operation, a really, really very, very powerful operation, and should be done really, really, I think that the mixed concept of the floppy Nissen should be well understood, and I don't know if all the surgeons make the surgery the same way. But we're talking about symptoms in the first year, in the first 6 months, in the first 2 years. But the problem is also to think that we try to offer a patient a surgery forever. And also with the Nissen, we know that that's not true, that at 5 years and 10 years, there is only 60%, 70% that really works. I don't know which is the long-term effect of the toupee, because it doesn't have symptoms because it's not so tight. But I don't know if the long term it always also maintain the efficacy in comparison with Nissen. Before that I prefer to offer most of the patients with a Nissen, but the most important really is that should be a really, and it's possible to do really floppy Nissen, short and floppy, that really you can go through the valves and there is no pressure on the esophagus. But knowing that the first 3 months or the first 6 months after Nissen is more symptomatic maybe than after toupee.
Can I say?
I would like to know the opinion term effect of the toupee in comparison with the Nissen.
So there is some data from Lee Swanstrom in Portland, and there's some data out of Australia that shows long-term results of partial fundoplication is just about as good, if not as good, as a Nissen fundoplication. So that's why some people don't even do Nissens anymore. They'll just do the partial fundoplication only to prevent the immediate postoperative dysphagia that can drive some people crazy.
Correct. So we agree to disagree, but pretty much most of the people have shifted to doing a toupees, or like Professor Eduardo said, a very floppy Nissens is as good, or probably the one which should not cause dysphagia and yet give adequate relief. So based on evidence, we've already discussed this. Next slide, please.
Okay, so we discussed the indications for surgery, and we also discussed the choice of procedure, the procedures available. Now we have many junior surgeons and postgraduates also watching this program. I would like to pass on the message regarding the technicality of the surgery. The commonly done surgeries are Nissens, toupees, and sometimes gastric bypass. We'll discuss the indications later on. Let's move on first to the Nissen fundoplication. So we are following this position, the position of the patient, split leg position, surgeon operating from between the legs, and there is a reverse Trendelenburg or head and up position by about 30 degrees. The pot position is as shown here. We use 5 trocars. The epigastric one is used for Nathanson retractor, and the left upper quadrant trocar can be 5 or 10 mm. So may I come to Eduardo? Eduardo, you are using the same position, or you are having a different position?
No, we use the same. But we use the position. The only difference is that the subchifoid port, we use right lateral, because I prefer to take out the liver with instrument introduced to the right flank. And the only difference also that we try to use thinner trocars, usually a 10 and 4-5. I think, and I don't use the second 10 millimeters. Only with 4-5 is okay, in order to make a smaller scars. But it's the same approach, absolutely.
Okay. And you use a 5 mm camera or 10 mm camera?
Usually you have the 10 camera, the 10 because, but if you have a 5 with a very high quality, you can use a 5 also. In a patient with a short distance from the umbilicus to the typhoid, we put the umbilicus, the scope in the umbilicus. But usually I like to put the scope higher, usually in the middle between the typhoid and the umbilicus. A little right.
Sunil?
Okay. Yeah.
Yes, the setting for the theater, I think you can do French position like what you have shown. To me, for upper GI and also for bariatric cases, I'm going to be standing on the right side of the patient, and the patient is going to be in the supine position. The patient will be in reverse tenable position during the procedure, so no split leg. But anyway, it depending on the preference of a surgeon. But anyway, they are the technique. Thank you.
And what about your port position, Suket?
Yes, we start with the camera port will be off midline to the left side of the patient. That would be going directly to the EG junction, so that the camera port. For my port as a surgeon on the right side, it's going to be 2 port on the right side of the patient, which gonna be 10 mm on my right hand side and 5 mm on my left hand side. So that 10 will be going for the suturing and also the needle holder. My assistant would hold the camera and 5 mm on the left side of the patient. Yes, I do use the Nissen retractor.
Okay. Okay, so Seth, you can go on.
Yes, I think I finished my presentation. I think 2 hands on the right side, 5 and 10, and my assistant going to hold the camera with the left hand side, and the right hand will be 5 mm for sitting in the procedure, and 5 for Nissen.
Okay. So, Dr. Murthy, can you describe the procedure for juniors? How you do your Nissen Fundoplication?
So the position, I agree with you. That is a standard position. The choice of energy device for me is ligature. It's a duck-billed or Maryland tip ligature. We've used harmonic in the past successfully. There is absolutely no problem with it. Now, just like how they showed, we go through the pass. It's basically 4 levels of dissection. Get to the pass, intra-abdominal layers, and then get to the peritoneal reflections, and then get into the perihiatal dissections, and then get into the mediastinal dissections. That's the 4 steps of it. Now, some of them have concurrent hiatus hernia. We have reduced the stomach back into the normal abdominal position before we start dissecting to give us a clear view of it. And just like how the operator is performing, circumesophageal, reflect it all the way down. That is a very tricky bit. The bit which they are showing, which they have shown at that point, 4 o'clock position, is a tricky bit, and getting that right is normally what is really tricky, particularly in patients with large hiatus hernias. Getting through to that is really tricky. Now, in a handful of patients, we have to mobilize short gastrics. Majority of them, we get a reasonably floppy stomach without mobilizing. So I don't routinely mobilize short gastrics. But I have worked with people who routinely mobilize short gastrics, and it's a good outcome. It's a good procedure to do. But I don't routinely do that. And then it's a 360 wrap for me. For me, it's always Nissen's. So deliver it behind the esophagus. I'll just let this person do the hiatus dissection so I don't talk over it.
That's fine. You can go on.
Yeah, so deliver the wrap behind esophagus. And then what I normally do is I secure stomach at least at 2 points as a gastropexy. And that is a technique I've seen some of the Australian surgeons doing who are closely associated with the Adelaide unit, and that seems to be working reasonably well. So yeah, hiatal closure, routinely insert a biological mesh to repair the hiatus. Routinely insert a biological mesh to repair the hiatus. If you have breached hiatal peritoneal layers, it is sensible. I currently have, in the last 2 years data, I looked up in preparation for this. I have 2 recurrences of hiatus hernia repair. It's IAGES or Stratafix, one of those sutures which we use for this.
So we come to data later on, Murthy, but you already generated very good interest. Now I come to Eduardo.
Yeah,
Eduardo,
I would like to be slightly controversial. I don't want to be completely bland.
No, that's fine. That's fine. Now, Eduardo.
Yeah, and then what I learned from probably one of the best surgeons I've worked with, Paul Super, is using Stratafix, the self-fixation mesh for hiatus repair is a very slick way of doing it. And
Murthy, can I come back to you? Murthy, I'll come back to you. I asked Dr. Eduardo, what about division of short gastric vessels? What do you believe?
In relation to?
Doing division of short gastric vessels while doing Nissen Fundoplication. Do you always do? Do you selectively do?
Yeah. No, when we talk about a Nissen operation, Nissen means section of the short vessels. Always, if you don't short the short vessels, you're not doing a Nissen. You are doing a Nissen Rossetti or something like that. My feeling is that was something from a surgeon from, I don't remember the name now, from the Los Angeles, that he said that the reflux surgery should be done from left to the right. That means to short, to sever the short vessels and to see the left pillar of the crura. I don't agree with the operation because they make they cut all the large curvature. I understand that only you need to cut 3 or 4, 2, 3, 4 vessels in order to have absolutely the fundus of the stomach absolutely free. But for me, it's mandatory. In all the cases, we oblige to the surgeons to make a section of the vessels. And I think that this makes less tension and avoid dysphagia.
Okay, good.
We're not talking about the Nissen. We're not talking about another thing.
Yeah. So I go to Barry Salke. What about division of short gastric vessels, Barry?
I agree 100% with Eduardo. If you're talking about a Nissen fundoplication, that is division of the short gastrics. Otherwise, you're talking about a different operation. So when I do a Nissen, I divide the short gastrics.
Right.
Yes.
Now second interesting point was using the biological mesh. Do you agree? When do you use?
Why?
So, Eduardo.
Okay, conflicting matter. I think it's a very conflicting matter. I think that because from my point of view, is the reason why endoscopic surgeons need to have evidence-based medicine. There are only, from my point of view, I think that there are only 2 or 3 papers that really demonstrate the advantages of meshes in hiatus. It's a very controversial. One is from United States to show a very bad, really, for me was a surprise, a trial that demonstrates on a very good effectiveness in 6 months, but at 5 years, there were nothing. There were the same relapse with mesh and without mesh. And from my point of view, the most important is the paper from Watson in Australia, comparing mesh, no mesh, biological mesh, plastic mesh, and no mesh. and they show no differences. I think by the other side, there is a small, really probably very small, but very severe complications of meshes in the hiatus. And I leave some of these cases. If for that I try to avoid to put any mesh unless the case that you really have a big problem to close the pillars or the pillars are very fragile. This case, by example, they have a wonderful pillars, the patient is perfectly closed, and in my opinion, my personal opinion, don't need any special foreign body.
Okay. Barry, your opinion on use of biological mesh for Nissens routinely?
I'm beginning to think that Eduardo is my brother.
So we are happy that we brought both of you on the same platform today.
Yeah, go figure.
Yeah.
So, I mean, listen, I agree with basically what I said. We need evidence-based medicine to really be sure about, as best as we can, what the end results are going to be. Clearly, it is controversial. If you put, there seems to be data to show that even though it's a small percent, there can be really big problems postoperatively with the placement of a mesh, both biologic and non-biologic. I was a little surprised with the biologic mesh can have problem too, but they can. And we have to remember that we're talking about benign disease here. This is not malignant disease. It is terrible to convert a patient that you're trying to do this for lifestyle changes to something that's really serious that puts them at risk for their life. And a mesh complication, I'm sure everybody here on the panel has operated on patients who have had mesh complications. They are disasters, and they can be really, really big time problem for a patient for the rest of their life when they have a mesh complication. So I do not routinely put a mesh in the at the esophageal hiatus ever.
What about pledgets? What about pledgets, Barry?
Okay, so yes, I do use pledgets. It is, you're right. Non-biological synthetic material that's at the hiatus. I have never seen any of my patients, as of yet, have a pledget complication. I have seen many complications from a mesh, both biological and non-biological. And they are really difficult cases to deal with.
Okay, Roy, your comments.
Yes, Neil, I think looking at literature, there is a large study from Oschlager's group, which he published in 2012, and he said that biological meshes seem to be beneficial to prevent recurrences. The same group published in 2018 the follow-up of the same patients, and they show that biological meshes have no role to prevent recurrences. My own feeling is biological meshes, if you do use them, are simply postponing the recurrence. If you do have to use something, and what I've been using for the last 6 months in very selective patients, and those are very large paraesophageal hernias with big defects and elderly patients, is using a phasix mesh. This is delayed absorbable, that will go for a year, but I have no data. I've done only 3 or 4 patients with the phasix, but biological mesh for me is a no-no based on evidence.
And no routine use of mesh in your Nissens.
Oh, 99% no mesh. Very, very selective paraesophagals or recurrent hiatus hernias with very wide. And I want to point you to a paper in surgical endoscopy by Dr. Chaubey from Delhi, where he said that if your intercrural distance is more than 5 centimeters or your crural pillars are very weak, only then you would put a mesh for a primary hiatus sliding hernia. Paraesophageal hernias, Sunil, are a different ball game. I don't want to discuss about them.
We'll come to it. We'll come to it. Yeah. Okay. So they're already starting to disagree. Now, few panelists already said to us that they prefer doing a posterior partial fundoplication, particularly in elderly patients or the patients who are having poor motility on manometry, or they are having symptom of dysphagia. So, Roy, what is your technique? Very briefly, can you describe your technique of doing a posterior partial fundoplication?
So pretty much what you have done, Sunil, I am a believer in extensive mediastinal dissection to get about 5 centimeter intra-abdominal length of esophagus. Number 2, I believe in quantitating the intercrural defect after suturing by putting in a Fogarty's catheter. I never use the esophageal bougie. I will always divide the short gastrics for a Nissen's and selectively for a Toupes. But pretty much what I also think we need to discuss the length of the wrap, because I think I am a believer in short wraps. I never do a wrap more than 3 centimeters. I actually put in a scale to measure the length of the wrap is 3 centimeters. If I'm doing a Nissen's, then I would anchor the wrap to the crura, but in 2 ways I wouldn't anchor the wrap.
Posteriorly. Okay. So what about anterior partial fundoplication? Does any of the panelists is doing routinely anterior partial fundoplication? We are seeing in the data some evidences are coming forward that it is as good as posterior partial fundoplication. Eduardo, would you agree?
Sorry, repeat.
What is your take on anterior partial fundoplication?
The partial.
Reflux. Yeah.
No, you only in very selective cases. All patients or patients with a dysmotility. If not, I prefer to rely on Nissen. I prefer the Nissen.
Okay. I don't think anybody in the panel is doing anterior partial fundoplication for reflux. So we already discussed about the division of short gastric vessels. Majority of us would do division of short gastric vessels for floppy Nissen fundoplication. And Dr. Murthy already said that he would selectively divide the short gastric vessels. What about bougie? Roy, you said you never use bougie. Does anybody should use bougie?
I think you've seen some horror stories, Sunil, with bougies coming through the esophagus and perforating. So, and I don't think a bougie is required. We then moved on to using a gastric calibration tube like we use in bariatric surgery. Now we just put in a Fogarty's catheter after completing the wrap just to make sure we don't have it too tight. I would never use, for the last 10 years, I've never used a bougie.
Okay. Professor Barry Salke, in your department, is there any use of bougie?
Is that for me?
Yeah.
No. I think it's potentially dangerous. We do use bougies, but really for a very specific reason. Routinely, we would never use it.
Okay.
It's too dangerous.
So for the beginners also, it is not to be used. Barry?
For me, I'm sorry, I can't hear.
Yeah, Barry.
At the beginning, you mean a young surgeon who is just starting out, trying to get an idea. Well, hopefully that young surgeon has been trained by someone who understands what a loose floppy fundoplication is supposed to be. But if that is not the case, then either a 56 or a 60 sized French bougie would be appropriate for the first 1 or 2. It's you learn very quickly what it's supposed to look like. But once you've learned that, then I would not put it in. No matter how careful you are, there will be some instance of perforation of the esophagus, either in the larynx or at the bottom part. So if you have to use it to understand, to learn how to do it to begin with, okay, 1 or 2, but then you know. But I would not use it routine.
Okay. So Ted, what is your practice? Bougie or no bougie?
No, I'm also totally agree with Bali that the bougie or the sizer might not be necessary, but absolutely you have to know how floppy that it's floppy. So to me, I'm do very, very loose, very floppy for the fundoplication. So I'm not doing the bougie.
Okay. Eduardo, do you have any different view on this?
No,
use of
I agree also. I think that is I totally agree with Suzette. I think that you need to understand, to make a nice dissection, to assure that the Nissen will be floppy, and it's very easy. Once you make the first stitch and you like you tent the wrap, and you see that there is a triangular space, that means that it's really loose. Because I never understood the bougie, because you are stretching something that is elastic, like this esophagus. When the esophagus come back again, probably if the wrap is too tight, it can become too tight. I prefer just to make a very careful dissection, a very careful preparation of the wrap. And in the case that we need something inside the esophagus, we prefer the scope. In case of reoperations, in case of difficult cases, etc., we prefer to use the scope than a bougie.
Yeah, Roy.
Maybe I want to ask a question to Barry, whether he ever uses an endo flip. A lot of American surgeons tend to believe in this OG junction distensibility and do an endo flip on table. Barry, what is your take on that?
I do not use an endo flip. I mean, I'm not against it, but I don't use it.
Yeah. Okay. So majority of the analysts don't advocate the use of bougie. Unfortunately, majority of the books are still saying that first for the beginners, 30-40 cases, one should use bougie, but I believe the chances of perforation are maximum when somebody is immature. So we move on. I think suture material we can avoid. All of us agree that we should use non-absorbable suture material for chloroplasty. And intraoperative endoscopy already answered by Eduardo. Now, post-op barium study. I saw at some institute it is being routinely done at 24 hours before discharge. Can I ask Roy, what is your protocol? You do barium swallow before discharge, or?
I would never do it, Sunil. I would do a gastrographin only in selective cases of very large paraesophageal hernias, or when I do a redo a hiatus hernia, second, third surgery where there's been a lot of dissection in the mediastinum, and I've been concerned about the esophagus. But I actually prefer to do an intra-op endoscopy if I'm concerned. So I would rarely do a post-op imaging study.
Okay. Eduardo?
No, I love to make the post-op control. I try all the patients go out of the clinic with a gastrographin swallow for two reasons. One is to check that all is okay. I have some cases of people that in the immediate postoperative have a migration of the wrap to the mediastinum in the recovery with some vomiting and the patient, and we saw that when we make the control. And also an aspect that consider interesting is from not medical legal, but just to have a reference of how the things went when you need to reconsider this patient if you need to reoperate. I like to have at least it's so easy and so quick that I prefer to test all the patients after surgery.
Okay, so gastrographin swallow in all the patients.
Yeah.
Okay. Barry?
I happen to agree with that, because about 1% of patients will have either dry heaves or vomiting from the narcotics that have been given to them or from the anesthesia. And I found that if you do that, if a patient vomits or even has a dry heave or has a difficulty coming out of anesthesia, there's a really good chance that they're going to break the stitch and the diaphragm in the recovery room, and they will herniate up into the chest. And it's a very easy thing for me to fix the next morning. It's a very simple operation to fix the next morning. And it can be very difficult 6 months later when all of a sudden you pick it up that the symptoms, the patient has recurrent symptoms or some issue. So I do it 100% of the time, and my incidence is at about 1%. I put it on anesthesia, actually. I think it's an anesthetic related issue. And I think it's very, very easy to do a gastrographin or some type of study the first post-operative morning. If it's okay, they leave. Not okay, I take them back to the operating room. And it's very simple to fix.
Right. Dr. Murthy, what is the protocol you are following in UK?
Routinely, everyone gastrographin.
Before discharge.
Yeah, it reassures us, it reassures them on the position, like Eduardo has said.
Okay. We in India, I think most of us are not doing gastrography swallow routinely. My co-moderator Randeep, what is your practice in Delhi?
We don't do any gastrographins. So yeah, once we are sure, like Roy mentioned, somebody where we expect a problem or what we've, then of course we'll do an intraoperative, test for any leak or any problem, or we'll do an intraoperative endoscopy. But by and large, we don't do a postoperative gastrographin swallow.
Okay. So now,
I do support the Indian opinion. So anyway, but I understand why Barry and Duero or Moti have done the study routinely. But anyway, we might do only those who have some symptom after the operation that we might think that the patient would have some symptom, some complication only. But we are not routinely doing it. Thank you.
I think logically it does make sense to do a gastrographin swallow before discharge, but it has not become a part of the protocol here. Maybe we can look into it, putting into trial for few patients and see and compare. Now, some of our colleagues have been exposed to this LINX reflux management system or magnetic sphincter augmentation. So may I start with Barry? What is your experience and what do you think about this?
I have very little experience with the LINX at our institution, so I'm going to defer that to someone else. But I also have to say, I have to take my wife to the doctor because she was in an accident 2 days ago, car accident. So I have to leave now. Okay. I want to thank everybody for allowing me the honor to be here, and hopefully I get to see you sometime soon.
Thank you, Barry. Thank you for being with us. We all enjoyed your company and looking forward to have you again in some other international webinar.
Thanks so much. Bye, everybody. Stay safe. Wash your hands.
Sure. Thank you, Barry. So may I ask the same? May I ask the same question to Eduardo? Do you have any experience regarding this?
No, I have not experience, but also want to say that it's some kind of ideas that it looks very nice, but I am afraid of that. It's difficult to me to understand something that is stretching the hiatus, and then I don't like this idea. If you remember the Angel cheek prosthesis many years ago.
Yeah.
With a lot of problems. I think that to put something that make force around of the hiatus, it looks nice, but it's not natural because I don't like.
Yeah, I think the literature also suggests the same only because it is indicated in a very mild GERD cases which can be easily controlled with PPI. It is not indicated in severe GERD for which we are normally doing Nissen. And there are some absolute contraindication and there are some complications also. So I think it is too early for LINX. So the trial have been done in 2007, 2008 and onwards. But there are some indications which will come to it later on, particularly reflux following sleeve gastrectomy or rarely reflux following RYGD, which we'll discuss later in the presentation. So, Randeep?
Yeah, I know we've been discussing for nearly 2 hours and everyone's quite exhausted. So we'll run through the slides a bit quickly and ensure that we finish in quick time. We won't delay it too much. Just coming from surgery to endoscopy. So Dr. Murthy, I guess you are doing a lot of endoscopies. So just a question on what are the endoscopic procedures that you are doing which have given us good results over a period of time? Dr. Murthy, are you with us? So I'll take the question to Dr. Roy. Roy, you do endoscopies yourself. Any experience on any of these procedures, strata or any of the staplers, the surgical endostaplers, or anti-reflux mucosectomies, or endoscopic full thickness plications, or transoral incisionless fundoplications. So any of
So
these.
Randeep, we did 2 of these. We have done as part of a multi-center study. We did something called the eagle claw, which is a full thickness fundoplication. We did 7 cases and we had a problem in 1, and subsequently the trial was stopped because of complications. We've also tried the strata procedure when it was reintroduced, basically for patients who have reflux but no hiatus hernia. But the pH data on these patients is quite disappointing. My own belief is when you do a strata, the radio frequency destroys the sensory receptors. So the symptoms do go away, but the pH data is showing almost 20-30% recurrence of GERD. So in my book, currently it is surgical approach, PPIs or nothing.
Correct. So that's what I was coming to. Where are the indications for these endoscopic procedures? Once a PPI fails, it's a diagnosed GERD, you would go for a surgical procedures. By and large, they mention in most of the data is that it's not suitable for grade B, grade C, esophagitis, and so on. And for grade A, you're in any case giving PPIs. So less indications for this. What is your comment finally? Roy?
Come again?
So I said, where are the indications for these procedures? When you look
None.
at the ones
0.
who have failed for PPIs, they just move on to surgical procedures.
Yes, if they fail PPIs or can't tolerate PPIs for any reason, they just go in for surgery. I would not do in my practice any endoscopic procedures for GERD.
Sure.
Another thing you need to mention is the ARMS. Professor Inouye from Japan has introduced the endoscopic mucosectomy.
Mucosectomies, that's correct.
But I suspect it's going to have the same death as the strata.
Correct. Next slide, please. So we move on. Endoscopy has less role in. So what about failure? So let's go to Sutep here. Sutep, the question is, the procedure was indicated. You've done the procedure. The procedure was absolutely fine. You'll still have a failure rate of about 10 to 15%, and particularly for recurrent reflux symptoms, which could be almost to the tune of all the reflux patients to about 61%. And dysphagia to about 24%. That's a grade A recommendation. What do you do for these patients down once they failed an anti-reflux surgery?
Wow, this is a very challenging patient group. So the patient did have the good result, and then they fail. So I think it means the procedure or this operation itself does work, but what happened and make the patient the recurrence. So I think we need to firstly sitting and talking to the patient according to, as we mentioned earlier, that this is lifestyle modification procedure. So we need to again review, and secondly, what we have to check is that we may need to go in. I mean, they'll put the scope in and have a look. Might be the herniation of the fundoplication into the chest, or the wrap has been open. This all we need to do. Finally, we also having to check for the stomach and the material itself. So this is tough. And also what we would like to do, it's also less options. So this is a very challenging.
Yeah, so Professor Eduardo, Dr. Sutep just mentioned that lifestyle modifications is what he would suggest to these patients, and probably get a CT scan, CT scan with a gastrograph and swallow or a barium, some radiological investigations to know if there is any anatomical problem, and then probably if there is, then probably consider a re-laparoscopy. What's your suggestion here?
Yeah, I think it's a very interesting group. I think from the surgical point of view for endoscopic surgeons, I think it's a challenging situation. Yeah, you need to keep calm, but if you select the patient, you have a good success. I absolutely agree with Sutep in the terms that you need to be very careful, talk with the patient, also to try to be very conservative. However, it will depend on the symptoms. If you have really a severe dysphagia, it's really a big problem. If you have a reflux, it's more easy to maintain. Obviously, you began with the conservative maneuvers like is dilatation in the case of stenosis. But however, if you have a case that there is not additional circumstances well evaluated with endoscopy, manometry, and CT scan, I think that the patient have a very good option if he is explored by laparoscopy. The figures, and these are constant figures in the literature in hands of expert people, is that you may succeed with 90% of the patient by laparoscopy, and you have a good outcomes in more than 75% of the patients. That means that really you can solve the problem. The most difficult situation here, in the case of redo, is the mesh. The mesh really is the situation that made the things much more complicated because the adherences are very important. I think that this is a kind of surgery that should be done by skilled surgeons with a lot of patients, with a flexible endoscopy available at the operating room. And the idea is to take out all the previous operation and redo new closure, new fundoplication, and sometimes a mesh. This is probably my idea.
Excellent. So excellent points here, that if we are going to consider a redo fundoplication, should be done by a very experienced surgeon, somebody who is experienced enough to do these procedures, and only then undertake this procedure and then do it. Otherwise, best to avoid or refer it to a place or a surgeon or a surgical team who are experienced enough to deal with these procedures.
Absolutely, absolutely. You need to take, there is a key, the most risky situation is the perforation of the esophagogastric junction when you take out the wrap, and also obviously the symptoms that you may induce with a bad situation. But I want to say also that in the hands of a skilled surgeon is simple that maybe you can realize. Really, it's a very nice operation, I think.
Sunil.
Okay, so we already started discussing the indications and the important principles we need to follow in redo surgery. So I would like your opinion regarding redo and revision fundoplication cases. You have one of the largest experience in the country. What are the things we need to safeguard before we contemplate this surgery?
So Sunil, there are three groups of patients. One is those who develop new symptoms like dysphagia, vomiting, or gas bloat. The second group is who never get response of the original symptoms, or the symptoms go away and they recur. So the first thing I do is evaluate a patient to see if the indications of the fundoplication were appropriate. For this, I will do an upper GI endoscopy, impedance, pH, manometry, and a CT. I think we have now more than 100 redo surgeries, and I think we have picked up 3 achalasias who had a Nissen Fundoplication done. So the obvious reason is you take down the wrap and do a cardiomyotomy and the symptoms are gone. The second thing we look at, where are the various problems that we have seen? One is inadequate esophageal window, too tight a closure of the crura, inappropriately done wrap, or a wrap migration. These are the 4 things we see. The commonest thing I have seen is wrap migration in about 40% of our patients, and 2 things can happen. Either a shortened esophagus will pull the esophagus and the wrap into the chest, or simply the wrap moves up on the esophagus. So some lessons I have learned is, one is mobilize the esophagus in the mediastinum much better. I need to get 5 centimeter length of intra-abdominal esophagus. This is very, very important in this situation. I've had to do a cholecyst gastroplasty in only 2 of these 107 patients so far. I think this literature is mixed. Some people, like for example, Dr. Demister, will do a lot of cholecyst gastroplasties. I have been able to, in most cases, been able to get adequate esophageal length, and have done a cholecyst gastroplasty, a wedge fundectomy in only 2 of my patients. So if the defect is more than 5 centimeters, I currently use a composite mesh. I'm currently using the physics, but you may use any composite mesh. In a redo patient, I only do a partial wrap. Number 4, I will always anchor the wrap both to the right cruise and the left cruise. And to be honest, I'm not too bothered about vagal injury. I think there is enough data that if you injure one of the 2 vagi, nothing much happens to the motility, gastric motility later.
Yeah, absolutely. Professor Eduardo?
Dr. Popato, I apologize sincerely, but I thought that the conference will be shorter because you not said, but I need to leave because I have a commitment. I really apologize because if I
No
didn't.
problem. No problem.
I've
We
been a bit-
enjoyed your company, Professor Eduardo, and thank you for being eminent faculty with IAGES. And we look forward to having you once again in this kind of webinar activities.
Sure, thank you very much. I wait all of you and people that are listening to us in Barcelona in 1 year. World Congress of Endoscopic Surgery, Barcelona 2021. Thank you very much, and congratulations for.
Goodbye, Professor.
Thank you.
Thank you
Bye-bye.
so much.
Thank you. We'll be there.
So Roy already mentioned all the points, but the picture may be dangerous to see, and we're not going to run the video. We'll move forward. But it is said that failure of fundoplication is so rare, but it is in experienced hands, but it does happen, and the failure rate at 10 years is 10 to 15 years. Most are managed within 2 years of the initial operation. Rep herniation has now become one of the most common mechanisms, and redo fundoplication is successful in carefully selected patients. It is more demanding due to dense adhesions, altered anatomy, inability to find the correct planes, increased complication rate as compared to primary anti-reflux surgery. And as Roy mentioned, most common complication does happen. However, one has to be very careful. But this is very peculiar. So I will ask some of the faculty, what do you do when you have pleural opening? Sutep?
Wow.
You are doing the fundoplication and you have pleural opening. What would you do?
Yeah, I think in case of redo, I would have my endoscopy available in my theater. So what I would like to do, I put the scope down, try to see the opening, and what we need to do, we need to repair and reinforce on that part, and we might change the plan a little bit. If you would like to do, I would think that we may adopt the principle of having the myotomy open in a hell myotomy. You have to close and also put the fundoplication on top of the part of the injury. So I think this is what we have to plan ahead.
So for perforation, you are very right that you need to identify that there is a perforation, close the perforation, and then do a fundal wrap. Roy, you must have had experience of pleural opening while doing fundoplication. What is the advice would you like to give to the?
So, to be honest, pleural openings don't bother me too much, and I have it quite often. I think you see it on table, nothing really much happens to the patient. The concern is the saturations may drop, the anesthetist has to be alert. The concern for me is if they get a pneumomediastinum, not a pneumothorax. And just for a small pleural opening, I don't do anything at all. I just ask the anesthetist to give forceful PEEP at the end of the procedure, and they can be extubated without an intercostal drain. We just keep them in the recovery for an hour, observe their saturations. Only if saturations drop, then we don't even do a chest X-ray as a routine. May I remind you that in the earlier days that a deliberate left pleural opening was created in order to get esophageal length. That is one of the techniques described in the 60s. So pleural length is not a problem. What bothers me is the perforation to the esophagus. Gastric perf also, that usually happens when your assistant is pulling overzealously on the stomach, and that can be closed. Esophageal perforations are a problem. And as Sutep mentioned, then I would suture it in interrupted sutures, and I would in fact not do a posterior wrap. In that case, I would convert to a door fundoplication and cover the injury anteriorly. And I'd also do an intra-op endoscopy to make sure the closure is good, because that has a very high morbidity.
Yeah, absolutely. I'm just going to show you the defect here. Now, this kind of defect, if you are getting, how would you repair it? So we'll start with Sutep and then go to all the faculties.
As I see here, it's the opening on the cruise, right? That
yeah, there is a sliding defect and there is a adjoining paraesophageal defect.
Okay, what we need to do, yes, I agree with Roy that we have to, before we close the crura, we need to make sure that we have enough length of the esophagus in the abdomen. After that, what we have to do, we close. For this one, Mostly I will close the cooler posteriorly, but this one, looking at the ankle, I would do the anterior closure of the cooler. And what I need to do, I have to check for the size of the opening. If it's bigger than 5 years, this is the only thing that I may adopt the principle of having some reinforcement, and mesh would be used in this case.
Yeah, Dr. Murthy.
I don't know what the excitement about this pleura thing is. We've seen so many times. Once we had to put in a drain, they woke up fine. They went home the same day because all ours are day case fundoplications. They go home by the end of the day. And esophageal, again, a door fundoplication, slap a stomach and secure it is all we ever had to do. 2 esophageal perforations. So far, needed a few days of NG feeding.
Yeah, Dr. Murthy, I was
our limited experience has been.
Are you getting the picture on your screen?
Yeah, it's a beautiful.
Yeah. So how would you repair this kind of hernia?
You're going to throw things at me. And I say these 2 words. Biologic mesh.
So you would repair and put a biological mesh and come out?
Happily.
Okay, okay. Roy? Your audio is off.
As usual, I have to differ with Dr. Murthy. I am anti-biologic mesh, having burned my fingers many times. If you look at this defect closely, what I would do, unlike SUTEP, is I would do a posterior repair of the sliding hiatus hernia. This does not look like the defect is more than 5 centimeters. As far as the defect on the side, I would much rather put a composite mesh on the defect on the side, because that mesh would not be in contact with the esophagus. So I would close there is no way we can close both defects, because the left cruise is going to get pulled in either direction, likely to split. So I would do a posterior closure of the sliding defect and then put a composite mesh on the defect on the side. Sunil.
Can I just add 2 seconds here? I won't take too long. I won't take too long, promise.
Yeah, go ahead, go ahead.
Now, I've never bridged a hiatus yet. Always close them. Always have gastropexy. That is a rule. And number 2 is the only esophagectomy we did post mesh was a composite mesh, and it eroded through esophagus perfectly. The poor patient was high BMI, and he went home half of what he was. And we ended up doing an esophagectomy because it eroded through. There was nothing we could do to get rid of it. It's anecdotal. It is not a huge number, but my anxieties come from there. And so far, it will happen to me. It will happen to me one day. I will be bitten, promise. So far, we haven't had an issue with this.
Yeah. My idea of showing this large gap was only that such a large gap would definitely require a mesh, some kind of mesh, whether you use a biological or a composite. And then it brings us to the topic of mesh, which is most controversial. So yes, no, when. So we already discussed that when the defect is 6 centimeter or larger, then we would definitely use some kind of buttressing, which may be absorbable mesh or a non-absorbable mesh. Regarding biological mesh, there are controversies that it does get absorbed, and at the time of 2-3 years, when you review, the literature doesn't say that it actually prevents the recurrence. But initially, it helps you tide over the situation. So, Dr. Murthy, you are one of the most staunch believer of biological mesh, so I will start with you.
So, if you are
routinely using the biological mesh, so you must have used quite a few. And what is your experience at 5 years, 10 years?
Okay, Dr. Popat, I will cheer you upon this sentence. The biologic mesh we do is manufactured in Gujarat.
Very good.
Okay, So please agree with me. Somebody has to agree with me.
Right.
Okay, that's number one. Number two is securing a biologic mesh which gets absorbed and which almost is never seen radiologically with reasonable clinical outcomes with non-absorbable sutures is standard. Now, in my limited, 400 so far, I haven't seen much excitement from biologic mesh, and every time we use composite meshes, we had some problem or the other. We had collections, we had infections, we had one erosion which needed esophagectomy because it was refractory and all sorts of stuff. So I'll reconsider my options when I have an issue. At the minute, touch wood, I got away with it. It will happen.
Okay. So that any use of mesh in your practice?
Yeah, tough. I know that if it's bigger defects, I would adopt the using of mesh. But what type of mesh? As we know, the biological mesh might be working, but for long term, you can see that it also doesn't show much the improvement in prevention of the recurrences. But anyway, I choose to use what you have done for the case that you presented, but with the very careful information that this is the benign diseases and the patient have to be with the measures of foreign body for a long time. We don't have enough data to support of these. And if you ask the esophageal surgeons, they would say that never ever use the permanent mesh for the esophagus because they have done a lot of esophagectomy for the complication of meshes. So I myself, if I have to design, I would do what you have done, but be very careful and follow the patient. It's tough.
Yeah, it's a difficult decision to make whether to use the mesh or not. And when we do use it, it is with the understanding that there are chances of complication. We need to explain to the patient and then use it, and then keep the patient in the follow-up and mention everything in the discharge summary regarding the use of mesh, which type of mesh, and the placement. Roy, any comment on use of mesh or complication you would have come across?
Yeah, I've seen my own complications, and I went through various phases. I started life in the early 2000s by using a Gore mesh, PTFE mesh, which is no longer available now, and probably it would have had the lowest incidence of erosions, but the problems were capsule formation infection. Then we moved to Proceed, then physio meshes, then the various mesh. We went through a period of using porcine biological meshes, but as the literature became more and more evident, it became very clear that biological meshes do not help in recurrence. Sorry, Dr. Murthy, I'm reiterating this. And I've come back to using composite meshes, but I use them very selectively. And my criteria is the defect intercrural distance is more than 6 centimeters. If the crura are tearing, very thinned out crura, particularly in very elderly patients, redo surgeries where the crura are already macerated, or in very large paraesophageal hernias, or in very elderly patients, say 70, 80 years old, but I don't expect a long-term life expectancy. Those are the patients I am more happy to use a composite mesh.
Yeah, good. So we'll move on to the last topic of discussion today.
So we've had a lot of discussion. It's already been 2.5 hours. So what we'll do is Dr. Subhash Khanna, we'll just invite him. He'll rejoin. He's actually left. He'll just rejoin. And once he rejoins, he'll give just a vote of thanks to all the panelists and everyone who's viewing us. I've just talked to him. He's just rejoining. So let's ask the next question. And as soon as I see that he's rejoined, we'll go back to him and have him give a vote of thanks. So meanwhile, what we'll do is that, Sotep, this is your domain, GERD and morbid obesity. You deal with it all the time. So tell me what would be your choice of procedure here? Patient is a symptomatic GERD patient. Patient has got morbid obesity and has come to you. Your choice of procedure here.
Thank you for giving me this issue, because it's been evidence that if the patient does have reflux and also obesity, the treatment of choice, globally, I would say that it bypass. But anyway, it doesn't mean that you cannot do sleeve, because also sleeve gastrectomy also having shown that those who have reflux also have an improvement. On the other hand, the sleep itself also increase the incidence of reflux. To me, I myself, I would discuss with the patient and my MDT team that the patient does have reflux, so a choice would be a bypass. But if the patient very hesitate to do the bypass, because the bypass, as we know, that the patient have to do a lot to adjust and also to adapt to the new procedure. In this case, if we do discuss and the patient would like to do a sleeve gastrectomy, that's also a choice, but you may need to add some procedure to prevent the reflux to be worsened. For example, we may need to repair the small hilar hernia, which might cause the reflux. And also some would do the closure of the cura, and some study will show that you can do even a fundoplication for sleeve. So I myself, this is my protocol to treat for the obese patient with reflux.
Okay, so sleeve or Roux-en-Y gastric bypass with a crural closure would be your first choice procedure here. Either of these two procedures, correct?
Yeah, that's right.
So the other question is that, let's say you do an RYGB, you do let's say a fundoplication. The fundoplication fails. What is your next choice procedure? The patient still continues to have symptomatic GERD. You've already done a fundoplication here. What is your next choice procedure there?
So it become more difficult. So just not talking about modification or medication. So going to the surgical part, I think what we can do next, mostly the reflux after bypass. I would think that might be because of the pouch might be too big. What we can do, you can do the bagotomy added on the bypass. What I'm doing a study here is that the technique of bypass we do the fascicular technique, not the perigastric technique. So that also we try to see the difference, the acidity after the procedure. So, but anyway, the bagotomy might be added to treat for the reflux after bypass.
Sure. So what I'll do is I'll just break for a second, and Dr. Subhash Khanna has already joined us. What I'll do is I'll just request him to come over and give a vote of thanks. To introduce him, he's the past president of IAGES. He's the organizing chairman of the World Congress, which is going to be held in India in 2024, the WCES, and he's also the international academic coordinator for the IAGES. Professor Subhash Khanna, please, for your vote of thanks.
Thank you. I'm sorry if I'm interrupting. I hope I'm audible. Thank you. I had to leave in between because there's an emergency lined up where I have to do a presentation. Lip, thank you very much for that introduction. I just simply, before I thank all the panelists, I wanted to say what our president did. In the beginning, he did what we say, finding opportunity in diversity. So we started national webinars. We were almost first to start, and that ended up with a new beginning of international webinars. And here we are with all the expert panelists, with the moderators and our experts. I thank each one of you, Barry, Professor Eduardo, Suthet,
Murthy, all of you, Roy Patankar, and Nishan, my friend Nishan. I will not forgotten the hospitality by him when we went to Maldives. Eduardo must be very busy with preparations for Barcelona World Congress. And Suthep, I missed your last meeting. So special thanks to our moderators, President-elect Sunil Popat, and Roy Patankar for a wonderful webinar. Thanks to all the overseas faculty and for being with us, and hope we will meet soon in IAGES Coimbatore. I invite you all there to be with us. For all the overseas faculty, please do join us. And as an organizing chairman, I think for us, the World Congress is around the corner. So we have started making all the preparations. Please do join us in organizing and also in attending all our future meetings. Thank you very much to Murthy and all from the West. A very good day and good evening to all our people from the East. Dr. Suthep is there. Thank you. May I request to be, may I leave the meeting now because I have to just the surgery. Thank you and good night.
Thank you, Subhash. Thank you for your kind words. And we can see that even at this time in the evening, you are busy with surgeries.
Yes.
So enjoy your surgeries.
Thank you.
Okay, Sandeep.
Yeah. So can I have the slide, please? Yeah. So so well said by Dr. Suthep that generally this is a paper which has been published just a couple of months back, and this was on gastroesophageal reflux disease, obesity, and Roux-en-Y gastric bypass. And generally the recommendation is that if fundoplication fails, convert it into a Roux-en-Y gastric bypass along with the crural closure if it's not been done. So fail fundoplication, convert to a Roux-en-Y gastric bypass. But if a Roux-en-Y gastric bypass also fails at times, which can happen because you've left a big stomach, bigger parietal mass, parietal cell mass, and therefore sometimes a Roux-en-Y may fail as well. You can do a modified fundoplication with a remnant of the stomach. You can do a strata procedure or a links procedure. But the data here is only anecdotal at best. So by and large, the mention is that Roux-en-Y gastric bypass with obesity probably is the best choice procedure along with the crural closure. This publication again in 2014 mentions the same. Next, please. So we've already done that. So finally, in conclusions, my friends, we've had a long discussion, excellent discussion, and I thank you all for that. So some of the salient points or take-home messages that laparoscopic anti-reflux surgery is the gold standard for moderate, large hiatus hernias and indicated for GERD patients. Nissen's fundoplication of floppy Nissens in patients with normal esophageal motility is a preferred procedure associated with low rate of dysphagia and a low rate of recurrent reflux. But like I said, a floppy and a good mobilized Nissen's fundoplication. A toupee fundoplication is associated with a lower rate of dysphagia, acceptable rate of recurrent reflux, used in patients of higher chances of dysphagia, elderly, which was mentioned very clearly by Roy, Barry, and Eduardo, over 65 years of age, reduced esophageal motility, a small and rigid fundus. All those toupees is probably the first choice procedure. Overall complication rate of anti-reflux surgery is low. Use of mesh should be restricted to repair a large paraesophageal hernia, which we've discussed. Biological mesh is a first choice for Dr. Murthy. Phasics mesh is the first choice for Dr. Roy. By and large, most of us are either using phasics or using composite meshes. And again, mesh used for recurrent hernias. Revision anti-reflux surgery can be done effectively by a competent surgeon, or more importantly, by an experienced surgeon for recurrent reflux following previous laparoscopic or open fundoplication. RYGB, first choice procedure for GERD patients with morbid obesity.
Okay, thank you, Randeep. And we leave everybody with this slide that these are the tips which the panelists and the distinguished faculties have suggested to do a proper application. Always do proper hiatal dissection. Use a caudal traction properly. Do not miss the uppermost short gastric vessels because it will increase the tension on the rep when you are doing Nissen. Preserve the vagal nerves. Be careful with the esophagus and G junction to prevent perforation. Ensure adequate length of abdominal esophagus. As time and again we have said during this webinar that you need to have proper length of abdominal esophagus. Avoid injury to liver to prevent the bleeding. Be aware of accessory left hepatic vessels because it is present in 20 to 25% of cases, and if these are the major vessels, then you need to preserve them. Ensure that the fundus of the stomach is not retracted back when left alone. And make sure that the rep is not under tension. With this, we conclude today's international webinar. We thank each one of you, starting from Professor Barry Shalke, Professor Eduardo, Dr. Suthet from Thailand, Dr. Roy Patankar from Mumbai, Dr. Ahmed Nishan from Maldives, Dr. Murthy from UK, President Dr. Raman Goyal, and my co-moderator Dr. Randeep from Delhi. We really enjoyed your participation, and we look forward to having your presence again in this kind of international webinar activities under the platform, on the platform of IAGES. Thank you all, and bye all.
Thank you.
Thank you very much. Thank you. I enjoyed it very much. Thank you.
Thank you.